Today I'm going to discuss of AVF care in hemodialysis. And all of you know that AVF care is very important in dialysis patient. Start with the history of vascular access. Previously, before AV fistula, the external AV shunt, Quinton and Scribner, started with a elastic tube connected to a Teflon cannula. And there is a problem with thrombosis and infection. And later, in 1961, invention of how the femoral artery catheterization for hemodialysis by Sheldon and colleagues. In 1966, Brescia Semino, Italian scientists, surgeons, they started creating the endogenous AV fistula. This is the axis of choice for maintenance hemodialysis today. There are a lot of other things. I'm not going details like graft and AV graft and synthetic bridge graft and tunneled catheters. Newly, that is recent advance. Like in 1918, they started the double lumen tunneled catheter and all this. So this is a scientist who invented the AVF, the Brescia and Semino, and they started constructing arteriovenous fistula. This is the most commonly used surgical techniques. This is the side of the artery to the end of the vein. At the wrist, that is the anatomical snuff box or wrist. What are the common vascular access we can use for hemodialysis? The commonest is AVF, AV graft or catheters. Catheters can divide into femoral, jugular, and permacath. What is the ideal vascular access for hemodialysis? Ideal vascular access is which provide high blood flow rate during dialysis, and it can be used very instantly after immediately we can use the access and no needles. The survival of the access should be long, and the complication rates like thrombosis, infections should be low, and patient should be very comfortable with the access and minimal cosmetic effect. If you look at the end-stage renal disease prevalence from 1980, you can see that it is increasing. The number of patients that the prevalent rate of end-stage renal disease is increasing. If you see the chart of vascular access initiation for HD, only 16% of patients after diagnosis of end-stage renal disease starting dialysis with AVF is only 16%, and 80% of patients started HD with the central vein catheter. This is one data showing this use at initiation on day of eligibility. We can see that the graph again showing that AV fistula use is less compared to the from the first session of dialysis. They taken in a different way, like eligibility criteria after 65 days, 90 days, and also we can see that AV fistula, the rate of initiation of AV fistula is around 10 to 15%. So the concept of Fistula First Breakthrough Initiative, that is by Kidney Disease Outcome Qualitative Initiative. What is the purpose of Fistula First? That is to increase the number of successful AVF from 20% to 60%. This is to challenge in future is to optimize vascular access practice pattern. The target is to autologous fistula placement in 70% of prevalent hemodialysis patient. It's also showing that in US, the usage of central venous catheter rate has reduced, and now the term fistula first to fistula first and catheter last. So this graph showing from December 2003 onwards, we can see that the fistula first start date, then the AV fistula graph showing increasing the usage of AV fistula from 2003 onwards. We can see that there is an increase in the usage of AV fistula and decreasing the usage of catheter from the for initiation of hemodialysis for ESRD patient. So the first preference is AVF, followed by graft, and catheters the last option. So what is AVF? AVF is Achilles heel or lifeline for hemodialysis patient. It is the commonest form of vascular access for maintaining hemodialysis. So this is how AVF is creating. It's an anastomosis between an artery and a native vein that allow blood to flow directly from artery to vein. Commonly used non-dominant upper limbs. Its usage of AVF require maturation that takes 6 to 8 weeks period. The complications are less compared to AV graft and catheter. The long life patients on HD compared to catheters and graft. This is the circuit of AV fistula. It is a continuous circuit. It is not a creation at the wrist. It is a continuous circuit which start at the heart and end at the heart. Don't think it is only an anastomosis in the arm. Examination should not be limited to the site of the AV axis. Examination should also include remaining part of the arm like forearm, upper arm, shoulder, breast area, neck area, and face. What are the advantages? Lesser infection, lower tendency to clot, secondary complications are less, hospitalization rate are less, it allows greater blood flow, long-term patency, less cost of implantation and maintenance. What are the disadvantages of AVF? The maturation time, it will take time, 6 to 8 weeks, sometimes months also, in 2 to 3 months in rare cases, and failure of maturation also seen in diabetic and peripheral vascular disease or atherosclerotic disease patient. So more difficult to needle insertion, increase in size with the age and development of aneurysm formation, then cosmetic appearance of dilated veins with AVF. So for care of AVF, we need a vascular access care team that include trained vascular surgeon, could be cardiovascular surgeon, plastic surgery department, or who are well trained in the creating fistulas and surgical vascular surgery. Then definitely the role of nephrologist is there to take care of the patient on circadian dialysis, pre-operative and post-operative care, say dialysis nurse, dialysis technician, radiologist, involvement of radiologists and angiography team is very important to evaluate cases of AV fistula pre and post-operative complications, and pre-operative to assess the vein arterial status. All these things required radiography and radiography procedures to select the vein and artery, which site selection also important with the radiological evaluation. When we will create AV fistula, whenever the patient CKD, the glomerular filtration rate is less than 30 ml per minute, or serum creatinine level of more than 4 to 5 milligram per deciliter, or patients of CKD, they going to start anticipated HD within period of 6 months to 1 year period. And another group of patients, like those patients are on CKD patients are on CAPD, and for initial period of stabilization, or later some complication developed during the CAPD procedure, like mechanical complication or infectious complication, patient required hemodialysis through AVF. So CAPD patients in this category, like complications develop, we used to give hemodialysis through AV fistula. Then those patients, renal transplant patients, ESRD renal transplant, waiting for renal transplant, and more than 6 months and required regular hemodialysis, these patients are also required AV fistula. This is the vascular anatomy of upper limb. All of you aware and well thorough with the anatomy of the upper limb. There is a arch in the hand. It's created by the radial and ulnar artery. So you can see the radial artery and ulnar artery combined together and forming the arch and palmar arch. Then also we can see the bigger artery like brachial artery that is joining to axillary artery. Then there's a branch of axillary artery. Then the venous system also we can see that there's a lateral side there is cephalic vein and medial side is a basilic vein. So the radial artery, ulnar artery, brachial artery, and cephalic vein and basilic vein and medial incubator vein. These are the major venous and arterial system in the upper limb. The basilic vein drain the medial side of upper limb and cephalic vein drain the lateral side of the upper limb. There are types of surgical anastomosis. There are 4 different types of creating the arteriovenous fistula. The one type is the side of the artery. Anastomosis is to the side of the vein. The another technique is the artery, side of the artery connecting to the end of the vein. That is the classical braccio-semino-fist AVF. The side of the artery, the end of the vein is directly connecting to the side of the artery. Then another technique is the reversal of semino technique. That is end of the artery. Arterial end is anastomosising to the side of a vein. Then the last option is the end-to-end artery and vein anastomosis. So there are a lot of difference between the surgical anastomosis that will problem to the fistula. So what will happen in the surgical anastomosis? If you do side-to-side anastomosis, the arterial and venous side-to-side anastomosis, the technique is very easy, but the fistula has a highest fistula flow rate in all direction. You can see that there is a flow towards the endograde and retrograde direction, and also towards artery and venous side, both sides. So the second is the end of the artery connecting to the vein. In this situation, there is a minimal turbulence and distal steel and slightly lower fistula flow. The flow rate is very less. If you take the end of artery to directly connecting to the vein, so there is a flow rate is very low, and twisting of artery during construction is very can happen. If you look at the end of the vein to artery, that is the braccio-semino fistula. Here there is this is the classical AV fistula. It's a decrease in turbulence, highest venous flow directly from the radial artery, the flow towards the fistula, venous side, and minimal venous hypertension. This is more difficult than side to side. The technique is difficult in braccio-semino technique. That technique is difficult, but this is the classical fistula with the highest venous flow, minimum venous hypertension, and decreased turbulence. What is happening with the end-to-end anastomosis is end-to-end anastomosis, there is a least arterial steel syndrome and venous hypertension because there is no connection to distally. And lowest flow of the 4 configuration is the end-to-end anastomosis. These are the types of common AV fistula according to site of upper limb. Forearm, we can connect radial artery to cephalic vein, radial artery to basilic vein connection, sometimes radial artery to other transposition. In the arm, we can connect a brachial artery to cephalic vein and brachial artery to basilic vein, sometimes brachial artery to any other transposition. There are rare sites of anastomosis like ulnar basilic anastomosis and thigh femoral vein transposition, brachial access with the femoral vein, and brachial artery to antecubital vein, that's a loop graft. These are the common sites of creating the fistula in the arm, forearm, and upper arm, and axillary sites and femoral sites. And this is what is going to happen with the transposed brachial basilic fistula. This is the second step surgical technique, two-step. Initially, connection between the vein and artery, then they have to transpose the superficialization technique to for easy cannulation of the deep veins. These are the brachial fistula, radiocephalic fistula, and brachial fistula with the transposition. So what are the problems with the, there are some early studies showing there is the failure rate is very high in fistula. The study showing that it's around 15.3% failure rate. The patency rate 1 year follow-up showing 62.5%. So high primary failure rate and moderate patency rate at 1 year of follow-up was around 65% with the fistula. So what are the techniques we have to keep in your mind? The preservation of vein of CKD patient before creating AV fistula. So once the patient is diagnosed with CKD or risk for CKD, so whether she is not on dialysis, so you have to preserve the hand of the patient. So vein puncture during admission, IV infusion requirement of patient, do not use the dorsum of the hand for venipuncture and IV infusion, not at the forearm or upper arm, and to rotate venipuncture site. After 3 to 5 days, you have to change the sites to otherwise the patient developed infection, thrombophlebitis, and cellulitis. So we have to avoid all these things. To use a manual blood pressure device, don't use continuous monitoring of BP monitoring in ICU, and do not use the cephalic vein of the either arm of the blood draws, IV fluid therapy or drug infusion. Do not place a subclavian catheter or PICC line instead of this peripheral line. What are the preoperative preparation? Consider to the patient, informed consent. We have to select the non-dominant arm, reduction of non-maturing AVF via, you have to look at the radiological evaluation, radiological mapping of the arteries and vein to see the selection of the vessels, size of the vessels, and you have to see the calcification or thick any calcification and atherosclerotic occlusion of the arteries, and also check the difference in the pressure between two arms. The pressure difference should be less than 20 millimeter of mercury between two arms. Then check the Allen's test with the patient palmar arch, because I already explained there is a connection between the radial and ulnar artery and forming the palmar arch. So you have to, if you occlude the one artery at one hand, radial artery occluded, there should be a circulation, collateral circulation to the ulnar artery. So if there is some problem with the one of the vessel is blocked, so we can see some changes in the perfusion in the hand, changes in the perfusion of the hand, that will give an conclusion that patient has atherosclerotic disease of the radial or ulnar artery. Then check the arterial lumen diameter should be more than 2 mm at point of anastomosis. Then peripheral vein should be more than 2 mm diameter and no thrombosis or no anomalies in at proximal level of the venous system. The next step is once the fistula, we have to education to the patient. It's a post-operative care. Keep the dressing clean and dry. Rest and take medicine as prescribed. And also monitor the color, warmth of finger on fistula hand should be same as on the other hand. Experience in rise in temperature or numbness of hand or increase in pain, report to the emergency department or to the dialysis unit or nephrologist. Then post-operative care, we have to advise education to the patient, keep fingers moving, use soft ball to encourage vein development. Check fistula every morning and evening for thrill. Feel for buzzing sensation. Just keep the hand over the fistula and patient can feel the sensation of buzzing and brewing. Hold anastomosis side to hear and listen for brewing. Monitor blood pressure and hydration status to prevent excess clotting. Elevate the access arm to reduce edema and swelling. Report any abnormality to medical team. So patient education include good fistula care that will help maintain the patency of vascular access. Education is responsibility of dialysis nurse and nephrologist. Check the thrill at least once daily. Avoid tight clothing. Avoid carrying heavy object and avoid exposure to extreme heat and cold. And before cannulation, there are a lot of things avoid. We have to educate the patient, check blood pressure, avoid checking blood pressure on the fistula hand, and usage of IV drugs and venipuncture for blood collection and sleeping on the access arm. This should be avoided. And use the access site only for dialysis. Then wash the access with soap and water pre-dialysis. If look for any signs of infection, pain, swelling, redness, and absence of thrill must be reported to the dialysis unit. The fistula may need 6 to 8 weeks to mature and ideally should be more than 12 weeks. Next step is to teaching the patient exercise like isometric exercise should help develop both enlarge the vein by increasing the flow and build the muscle below to make the vein more prominent. Have the patient use light tourniquet or opposite hand to help encourage the vein with exercise. So you have to train the patient, not only the hand grip ball exercise, also other exercise like with a tourniquet or use the opposite hand and do the elbow exercise also. You can advise to the patient to for early maturation, and patient has to idea about how to get early maturation of fistula. The patient exercise 4 times a day, 5 to 10 minutes a day or more. Fistula hand-arm exercise before a fistula is placed and help the fistula mature after placement. How to know the fistula is mature? You can feel from soft and pliable to springy and firm consistency of the fistula while palpating over the skin. There is adequate dilatation of the vein and diameter of vessel is increasing. You can see that 2 mm to 4 mm, 6 mm, and 6 mm is a good matured fistula. And thrill is increasing and stronger, and brew is continuous with low pitch and no accessory veins detracting from the main conduit. What are the causes of non-development of fistula or immature, difficulty in mature of fistula? Depends on the location or some disease vessel, like a patient have some cardiac problem, poor cardiac output, or accessory veins communicating anastomosis with the artery, or just anastomosis stenosis, that is just above the arteriovenous fistula anastomosis. We can see that there is a stenosis of the vein. So this is called gesta anastomosis stenosis. This is a process of non-maturation or failure of development of the fistula maturation. What's the rule of 6S for fistula maturation? It should provide flow greater than 600 ml per minute. It should be greater than 6 millimeter in diameter. Then it should be less than 6 millimeter below the sink surface. The fistula should be less than 6 millimeter below the sink surface. Fistula should be thoroughly examined not later than 6 weeks post-op. At least 6 centimeter of vein required to cannulate. 6 centimeter of length of the vein is required to cannulation. So these are the 6 S. for fistula maturation rule, 600 ml per minute, 6 mm in diameter, and it should be less than 6 mm below the skin surface, and 6 centimeter of vein is length of the vein is required for cannulation. Next is cannulation. Cannulation is one of the primary cause of AVF failure. The sequence of needle puncture into the vessel wall lead to endothelial injury and intimal hyperplasia, infiltration, aneurysm, and hematoma. This will lead to failure of AVF, repeated hematoma, repeated aneurysm formation, pseudoaneurysm, infiltration, and all lead to more and more injury to the vessel and failure of fistula. So what are the standard precaution to before taking care of cannulation? Include strict hand washing, eye protection, use of face shield and goggles, mask, gloves, and use according to unit standard. Universal precaution is important. Preparation of skin, wash the hand with antibacterial soap and water before dialysis session. Clean the skin using 2% chlorhexidine gluconate solution with alcohol, and dry in time up to 30 seconds. Povidone using friction and circular motion. Leave the solution to dry prior to needle insertion. Do not touch skin after cleaning. If touched, then we have to re-cleaning. This is the techniques of applying chlorhexidine gluconate and applying sodium hypochlorite solution, and proper cleaning technique. You have to, in a circular motion, that would be ideal. From the site of cannulation, you have to start in a circular motion. That will be ideal technique for cleaning technique for before cannulation of fistula. Then use topical anesthesia on site of cannulation at least half an hour prior to cannulation. The needle type, there are two main type of needle: metal needle and plastic needle. This is the needle type, metal needle. The diagram of it has a wing and a hub. You can see the white hub. Then the shaft of the needle. This is a length. You can measure the length before cannulation. You have to see. For always check the needle. Any problem? Any cutting beveled edges? Any problematic? Wing is problematic. Shaft has any problem? So always check the needle before starting cannulation. It's a commonly used needle. The gauges we can recognize with the color and the thickness of the needle. You can see that the different types of plastic needle is also available. We can see that the length of the plastic needle is lengthier than the metallic needle. There are some general rules for cannulation. The initial cannulation will be sharp metal needle. Metal needles are either sharp or blendable. So blend is less injury to the vessel wall. To begin the rope ladder or rotating site technique, same site cannulation in order to establish tunnel track for the buttonhole technique. Plastic cannula can be left in the vessel for a period of time to develop. That is the buttonhole tunnel track. So there are some cases the fistula is very deep, and the deep vessels we have to make a track with a long plastic cannula, which would be ideal. Once the fistula is okay, then we can change it to the metal using the metal needle. The sharp needle used for the rope ladder technique leave a sharp cutting edge. The blend needle designed for the buttonhole technique, and this has a rounded on the top, no sharp edge. The black and red dot indicate the position of the needle even during the treatment. The wing color indicate the needle diameter. So this is the length of the needle. You can see the difference between the length metal and plastic cannula. The metal needle's length is 1.5 to 2.5 centimeter. The plastic cannula needle length is 3.8 centimeter for deep AVF cannulation. So the difference between the metal and plastic needle: the metal needle cannulation is easy, miscannulation is low cost. Severe vessel injury, the chances of vessel injury higher with the metal needle, then highest risk of needle infiltration during tapping or mid-treatment, or there is a limited area for cannulation, and metal needle less comfortable for patient arm movement during the dialysis. It is not suitable for deep AVF cannulation. And plastic needle, cannulation is very difficult, and the miscannulation is very high. The cost is higher. The vessel injury is less. The risk of infiltration is also less, and it is suitable for deep AVF cannulation. The rules of cannulation: the needle site selection, the placement of needle. You have to 4 to 5 centimeter apart, hub to hub. Needle is in the same direction. If the needle is in opposite direction, you can the length should be in between 2 to 2.5 centimeter apart is enough if the needles are in opposite direction. The insertion site, that is from the anastomosis, it should be away from 4 to 5 centimeter away from the anastomosis site. The needle should be inserted. The tip of the needle should be 5 centimeter away from the anastomosis site. This is the cannulation rule. You can see if you do opposite direction cannulation in a patient, can see that if you take a 1 inch apart, that is 1.5 to 2.2 centimeter apart, you can see that inside the vessel, it should be the space is bigger than the where you have started cannulation 1.5 centimeter apart. The space here will get a doubling, that is 3 inch apart space we can see. So there is a the less chance of recirculation and all these things with this technique. If your needles are very close and your cannulation very nearby in same direction, like in the anterogate direction with 1 inch apart, the needles are inside the vessel. You can see the needles are in the very closer. Also in the outside also needles are very closer, and inside also very closer. So the chances of recirculation, trauma, and injury vessel and the lasting of fistula is less with this technique. The rules of cannulation: venous needle pointing in the direction of the blood flow, arterial needle pointing towards the arterial anastomosis. Then another point is the venous needle must point towards the venous return, and arterial needle may point in any direction. Sometimes you're not able to cannulate in the arterial anastomosis side direction, so we can use the arterial needle in the towards the venous side also. May use in difficult cases, we can use the ultrasound mapping for depth and size of the needle where it is going exactly. At the initial stage, we can use the 17 gauge needle for first attempt, and for 1 week with 2 needle cannulation without complication, then shift to the higher gauge. This is the flow rate and gauge of the needle. If the bigger the needle, the gauge would be less and flow would be higher. The maximum flow rate is the 14 gauge needle, that is more than 450 ml per minute, and the 17 gauge needle, the flow rate is less than 300 ml per minute. Ideally, we'll use 16 gauge. Most of the centers will get a blood flow of 300 to 350 ml per minute with the 16 gauge needle. During choice, the needle size must follow the 2:1 rule. What is 2:1 rule? The pressure, arterial and venous pressure, we used to monitor arterial pressure and venous pressure on the dialysis patient. It should not exceed 50% of the pump speed. That is example, 400 ml per minute blood pump speed. Arterial and venous pressure should be arterial pressure should be minus 200, or venous pressure should be 200 millimeter mercury respectively. Should be not more than that. And arterial and venous pressure should not exceed minus 250 or 250 millimeter mercury to avoid damage to the vascular access. What is the back high to the needle? The arterial needle should always have a back high. Nowadays, I think both arterial and venous needles also have the back high. Should be smooth and flat so that this rim does not cut into the vessel during needle insertion or withdrawal. This will maximize the flow from the access, and also it prevents section of needle into the inner vessel wall and reduces the needle for rotating the needle which had trauma to the AV fistula. So there are a lot of advantage with the back eye. One is the maximize the flow and prevent suction and reduce the rotation of the needle. This is the back eye. You can see with the arterial fistula needle, we can see the back eye. This is the back eye needle flow. You can see in all direction. It will the flow will allow blood to enter or exit from both the bevel and back eye. Now, what is flipping of needle? The positioning of the needle. The position of needle, the insertion of angle of insertion is very important. That is 30° depending on the vein depth. The retrograde direction of arterial needle and bevel down cannulation increase the possibility of access failure. What is retrograde direction? That is away from the heart, and antegrade direction towards the heart. So antegrade direction of the arterial needle with the bevel up cannulation may improve the access survival. So this is the difference between the antegrade and retrograde cannulation. So another point is avoid flipping, rotating the needle, as this will cause scoring of the vessel wall and that lead to infiltration and hematoma. A flipping is essential, as in case of increased needle pressure must be done carefully to avoid damage to the access. Fistula needle with the back eye, the need of flipping of needle is decreased. Better use the ultrasound machine to determine the optimal cannulation site and assess the needle position before reposition of the fistula needle. Number of attempts. Better to use the portable ultrasound if available for assessment of needle position and vein depth diameter. If cannulation is failed, infiltration occurs, call the cannulator or clinical educator or senior members to recannulation of the patient. Do not push saline or blood if unable to aspirate blood from the needle. If doubt that needle has infiltrated, remove the needle to decrease the vessel damage and apply ice. If patient has received heparin, leave the needle in place, apply ice and give protamine sulfate antidote. Consider resting the access until infiltration and bruising has improved. Follow the unit policy, and the additional attempt must be done by an expert cannulator if the dialysis is life-saving, and better use single needle dialysis technique whenever it's available. The another is securing of needle. Needle should be secured at the same angle of insertion to avoid change in the needle position and minimize the risk of infiltration. It also should be secured during treatment to avoid accidental malposition and dislodgement of needle. The access limb and connection should be visible at all times and should not be covered with a blanket. Needle should be removed at the same angle of insertion. Do not apply pressure while the needle is in vein. Once the needle is completely removed, use a 2-digit technique for maximum hemostasis, one finger at the skin level and one at the vein level. The disposition of the needle follow the occupational health standard. You have to dispose needle as per the NABH protocol, biohazards and all medical waste system and all this. Make pressure at least for 10 minutes without releasing pressure. That will during the applying pressure ensure thrill can be felt in the excess. This much of pressure for 10 minutes, that will reduce the chances of bleeding and other complication during closure of the fistula. If thrill cannot be felt, remove the hand slowly and assess the thrill again, because we have to keep the hand. Pressure should be not very not allow the closure of the, not allow the fistula thrill should not be here. So we have to remove the hand slowly, then assess the thrill again, then ensure that the thrill is okay with the fistula. Troubleshooting needle placement and increase venous and arterial pressure. In this situation, decrease the blood pump speed, measure blood pressure and review previous clinical record to determine baseline blood pressure, venous pressure, arterial pressure monitoring, blood flow rate. You have to go through the previous chart and see what is happening with the patient fistula last time and last week and 2 weeks back. What was the problem with the patient dialysis? And you have to go through the dialysis chart for the last 1 month. Assess the thrill and bruit and observe for infiltration. and swelling or hematoma. Carefully reposition excess limb. Use a portable ultrasound to check the position of the needle prior to reposition or adjusting the needle. Carefully adjust tape or place a small gauze under the needle wings. If successful, secure needle in position with the tape while monitoring venous and arterial pressure. If unsuccessful, recirculate the patient blood and recheck needle position with portable ultrasound. If reposition is unsuccessful, remove the fistula needle. Before recannulation, ask help clinical educator nurse and repeat clinical assessment of AV access prior to repeating cannulation. Better avoid repeat cannulation. There are two techniques widely available, site rotation and buttonhole technique. This is also called site rotation technique, also called rope ladder or rotating site technique. Buttonhole is a constant site technique, the same site. You have to cannulate at the same time with the same track. So the rope ladder technique is the site rotation technique. That is, the cannulation sites are rotated up and down the AVF to use its entire length with equal distribution of puncture site. This is the classical technique used in most dialysis center. Cannulation in the straight line, at least 1 to 2 centimeters for each cannulation site. No need to straighten out by pulling on the vessel to cannulate because the vessel will retract into its original position when released and lead to an infiltration. This should be very careful. Most of the places we used to see that whenever dialysis staff used to pull the this thing, hang, they will make in a tight position of the skin. That will create a lot of problem. Once the vessel wall retract into original position, so that will lead to again infiltration of the site. So each treatment requires 2 new sites. What's a disadvantage of this technique? Small dilatation develop over the whole fistula, concern of one site itis. Advantage of rotation technique, lower rate of infection and help expand the lifespan of fistula. Changing cannulation site give the previous needle site time to heal and decrease the chance of formation of aneurysm. It is thought rope-ladder needle reduce the risk of stenosis. This is the classical rotation technique. You can see that there is a space between each cannulation on the artery side and venous side. The spacing should be equal. You can see that one side, second side, and third side. The space, there should be a space of between the rotation of cannulation. This is the poor technique. We can see that this without space, this is very close. In the artery site and venous site is very close. So this is an improper site rotation cannulation technique. Then buttonhole technique, method in which individually cannulate the AV fistula in the exact same spot at the same angle and depth of penetration every time. After about 10 cannulation using sharp dialysis needle, the buttonhole site will develop a scar tunnel track. This track is same as the pierced ear that scar tissue formed and will cause less to no pain or bleeding when cannulated. After the buttonhole is created, a blunt dialysis needle should be used, which eliminates risk of cut and bleeding into the tract. In difficult fistula or deep fistula, you have to use this technique, buttonhole technique. What are the advantage of buttonhole technique? Prolong the AVF lifespan, reduce needle attempt, reduce the pain, reduces bleeding and hematoma, reduce infiltration, reduce aneurysm, promote self-care and self-dialysis. In patient using dialysis at home, this technique would be better. Use blunt needle which require no safety device. What are the disadvantages? Require same cannulator, same angle, same location is required for the same, because don't change the direction, angle, and location. The cannulator also don't change it because that it should take time to develop the track. The higher rate of infection, the concern one side itis is very important with the this technique, and difficult with the fistula covered with the heavily scarred skin and large amount of subcutaneous tissue. These are the indication for buttonhole and rope loader technique. The buttonhole technique, AVF is short in length, a short usable segment, and tortuous anatomy, and AVF with aneurysmal dilatation use buttonhole technique. And rope loader technique, you have to get a AVF of relatively straight vessels, and patient has hand tremors and poor vision, and placement of needle with a buttonhole technique lead to creation of multiple tract within the buttonhole. And if the AVF is difficult to cannulate, use the buttonhole technique. If AVF is mature, then patient preference. Sometimes patient always say that they need the same site cannulation required, and needle phobia is there. Fear of needle, patient pain and other problem. You have to use buttonhole technique. The rope ladder technique we can use difficulty patient with a demonstrate difficulty visualizing the buttonhole site, or multiple tract within the buttonhole is a problem. So be careful with the buttonhole technique. We have to be in the same direction, same angulation, same person. That will create a good buttonhole technique. What are the common complications of AVF? Lymphedema, infections, aneurysm and pseudoaneurysm, venous stenosis, venous and arterial thrombosis, heart failure, congestive heart failure, Steele syndrome, and ischemic neuropathy. Just saying a few words about Steele syndrome. It's commonly seen with 5 to 10% brachial anastomosis, 10 times higher with radiocephalic AVF, and ischemia of hand caused by marked reduction or reversal of blood flow through the arterial segment distal to the AVF. That is hand ischemia is caused by marked reduction or reversal of blood flow through the arterial segment distal to the AVF. How to diagnose the Steele syndrome? By physical examination, Doppler study, and angiography. So what are the clinical features like pain at the rest? Patient complains of numbness of fingers and hand, sometimes ulceration, tissue necrosis, paralysis. And what are the risk factors for developing the Steele syndrome? Peripheral vascular disease, history of smoker, and diabetes history. These are the risk factors for developing the Steele syndrome. How to treat the Steele syndrome? If there is patients are asymptomatic or mild symptom, observation enough, and severe symptomatic cases sometimes require angiography and angioplasty, and to correct the arterial stenosis. Sometimes use the banding procedure. You can ligation in distal interval ligation of the distal vessels, that will reduce the pain and numbness and ischemia of the distal part of the fistula. When AVF closure is required, sometimes patient comes with a AVF rupture. The fistula rupture is due to infection or due to traumatic rupture or some other injury to the AVF. So these are the conditions required. Sudden closure of the immediate urgent closure of the AVF. Then another is pseudoaneurysm, risk of a rupture, and development of severe venous hypertension that lead to pain and edema of the distal part of the fistula. And in such a situation, we have to close the AV fistula and create another AV fistula or vascular access to the patient for dialysis. And patient with severe high output cardiac failure requiring repeated admission due to, if the cardiac failure repeated admission due to AVF arteriovenous fistula, required closure of the AVF fistula. Otherwise, patient will require the frequent development of high output cardiac failure. So we have to closure of fistula and alternative access for such a patient. And patient the patient AV hand is ischemic hand not responding to the usual treatment, we have to close the AVF. So some diagram of AV fistula in our patients. This is aneurysm, and this another patient have a central vein stenosis, history of jugular catheterization, central vein stenosis. She had venous hypertension. You can see that there is edematous right upper limb, huge edema. We have done the angioplasty 2-3 times to the central vein, because again repeatedly there is a recurrence of the stenosis in the central vein. These are the problem. Still we can do the dialysis through this because patient is asymptomatic other than this edema and severe edema of the upper limb. This is the normal cannulation of radiocephalic fistula. You can see that the second film, you can see there is a ulnar basilic AVF cannulation in our patient. And this is the antegrade cannulation technique by artery and vein, both in the same direction. You can see the different cannulation. And this is the needles of opposite direction. And this is a multiple surgery. You can see the scars of multiple surgery of a patient for AV fistula, one at the distal part and middle of the forearm, then also at the brachiocephalic side. And patient finally he have put a permacath and he was doing dialysis to permacath. These are the cannulation procedure. This is the patient referred from the outside centers from Chalakudi. They came with a large hematoma, and during dialysis fistula, not doing dialysis to fistula, after this hematoma, she has put a jugular catheter and doing the dialysis to jugular, and after the surgical treatment of this hematoma, again revision surgery of the AVF has been done and doing dialysis to the AVF. This is the another patient referred from the other places, showing there is a severe aneurysm of the AV fistula. He came to show this, what is the problem. You want to close the fistula, you want to create a new fistula or not. So because patient is apparently asymptomatic, no problem, fistula is good and good thrill and good bruit, but you just want to know that what are the things that should be done for this. This is our center data. We are doing HD initiation through AVF, 15 to 20% only still, and most of the patients started dialysis through jugular catheter, 60 to 70% of patient, and emergency situation using femoral catheter for patient came with fluid overload, chest infection, unable to lie down and non-cooperative due to fear, and next these patients are doing catheterization to femoral catheter. Then no patients are initiated through permacath. And this is the failure rate. There's around 5 to 10% of failure rate, primary failure rate, and secondary failure rate of 10 to 15%. The infection rate is around 2 to 3, and hematoma and aneurysm development 5% in our patients. So what is after this talk, my take-home message is patient education and stages of CKD, dialysis initiation, and all modalities of RRT to the patient once they diagnose the CKD. And all CKD patient vein preservation for AVF is very important. So in patient preparation for AVF creation when GFR less than 30% of progression to CKD. And refer early to our AVF surgeon and discuss the difficult cases. And postoperatively, education to the patient, how to care the AVF and exercise of AVF is very important for early maturation of AV fistula. Wait till maturation of AVF for initiation of cannulation or early cannulation. That will lead to a lot of complications like hematoma, infiltration, and failure of the fistula, early failure of fistula. And follow universal aseptic precaution infection. And educate our dialysis nurse technician about cannulation technique and care of AVF in HD unit. Ideal cannulation, good blood flow, adequate HD, improve quality of life of HD patient. Then proper anticoagulant to prevent clotting and thrombosis and bleeding. And extra or special care for difficult cases, very important. Thank you.
Thank you.